move on to the third session, which is going to be chaired by Richard Newton, who for once isn't speaking, he's chairing. So, Richard, I'll leave it over to you. Thank you very much.
Thank you very much, Tim. Very good to be here, and very nice to welcome Your Highness. Ladies and gentlemen, it's a real privilege to be asked to chair a session that is very close to my heart. And so in this pre-lunch session, we are going to consider equine conditions, health conditions, that we cannot ignore. And indeed, these are some really important emerging issues, and we've got three excellent speakers that are going to present to you today. There will be questions at the end, so if you can please save those up. We will take them from the auditorium, but also through Slido, so if you can put the questions online. And if you are watching this via Clip My Horse, then use the QR code in the corner of the screen, and your code there is hashtag NEF26. So without further ado and without stealing their time, it gives me great pleasure to introduce our first speaker. This is Hattie Bell. Hattie is an experienced equine veterinary surgeon. She's had a slight change of direction very recently, and we've been really privileged to have Hattie join the group, Equine Infectious Disease Surveillance at the University of Cambridge. She's providing some maternity cover for us, but she's really fitted in well into the team, and it's a great pleasure to have her here. So Hattie is going to give you some information on recent outbreaks, and particularly focusing on the importance of traceability and surveillance. Thank you very much, Hattie.
Thank you, Richard. Your Royal Highness, ladies and gentlemen, thank you for the opportunity to be able to speak to you today on this topic. It's a really great forum, and I know it's been touched on already, but traceability and surveillance is so important. We want to be able to move our horses, but infectious disease can have such an impact not only on that freedom to be able to move them, but on the economic stability of our equine industry as a whole. A part of what we do at the EIDS is to manage the International Collating Centre. So we collate infectious disease information from across the globe and send out a daily report. And this means we can see any emerging trends. So in the last quarter of 2025, you can see 642 reports, and these are really dominated by respiratory and neurological conditions. So with that in mind, I wanted to take you through a few cases today. EHV1 outbreak in Texas in November, flu update in France, and what might be an emerging threat to us, which is West Nile virus. So the first scenario was a women's professional rodeo competition in Texas in early November last year. There was around 1,000 horses came to compete from multiple states, mixed and unknown vaccination status, and it's a busy competition circuit. Many of these horses then moved on to other places, one of which was in Oklahoma. During this competition, 2 horses were admitted to separate hospitals and diagnosed with a neurological form of EHV1. This form replicates quickly, and it can transfer long distances because the horses are not showing clinical signs in this time. It takes a little bit longer to show. So this meant that there was a 9-day window when horses were contagious and mixing, and responses had to be really decisive and effective. The Texas Animal Health Commission then, learning that these horses were together, issued a holding order, which meant that any horses in contact had to be under enforced isolation, and they immediately cancelled all events. So using digital health IDs, these horses were traced out of the competition. There was over 2,500 traces performed by officials, and this also included any in contact or secondary horses. It's a really transmissible disease. These horses had to maintain a twice daily temperature under 101.5, which is around 38.6 Armani, for 14 straight days. Any horse that spiked a temperature in that barn, they had to return all back to day 0 and start again. So this is a map of all the cases reported to the EDCC, which is our equivalent in the US. And as you can see, there was a majority of cases in Texas. There was 47 in total amongst these 6 states. But just to quickly emphasize that while this was happening, there are other EHV neurological cases appearing sporadically. that happens normally in the demographic. Excuse me. Crucially, only 3 here were fatal, and the last cases were associated in the middle of December. EHV is a problem because it's multiple forms and it can reactivate in times of stress. So using the digital traces here, it was so crucial to containing this outbreak. As I said, this might be a little bit quick, but I just wanted to take you through some others. So an update on flu. Our EquiFluNet surveillance system is a platform offering insights into equine influenza across the UK and worldwide. Here we can see cases reported by country from the end of last year till now. And as you can see, France, which is this mustard colour, is really seeing a spike in cases reported. So Respay, which is our French counterpart, have reported over 70 cases, mostly in northern France. Again, a mixed vaccination status, and these are majority of trotting horses. Surveillance isn't just knowing where these cases are, it's using reporting systems to be able to control these outbreaks. So Respay have issued multiple calls for vigilance, which is essentially a heightened surveillance, so increasing, checking daily temperatures for any clinical signs, immediate isolation of horses, and minimising unnecessary movements. Thankfully, in the UK, we have had a few cases. One case we have had reported was, to us, was a horse returning from competition in northern France. It was vaccinated. And this is also a timely reminder of the standstill in British racing for 6 days in 2019 following a similar outbreak in northern France. So we have used our own alerting system here to really raise the awareness of this. But it's also a good moment to mention that while many governing bodies do only use an annual vaccination requirement, we do still recommend a 6-monthly booster. This means that horses have a higher antibody titer circulating, reduced shedding, and we know that horses that have been vaccinated in the last 6 months show a less clinical disease and severity of clinical disease. So the last bit I wanted to bring to you was some observations on what might be an emerging threat to us in the UK, which is West Nile virus. It is a concern for us because although the majority are asymptomatic, West Nile virus can cause a severe neurological condition in horses and people. It's a vector-borne disease, which means that you need a vector or insect to bite the natural host. In this case, it's a mosquito biting migratory birds. We are the incidental host, which means that although we can be bitten, we can become infected, we don't produce enough virus to be able to send this virus back to the mosquito to be able to pass it on. West Nile virus first appeared in the 1960s in North Africa, and in 1999 it really interestingly it entered in New York and spread completely across New York, the entire country in less than 10 years. So we now see it to be endemic in the US, and as you can see there are reports over here. Thankfully, in Europe though, we have seen slightly less dramatic waves. It is as unexpected with the mosquito transmission, known to be endemic in the Mediterranean. And this is a map produced by the European Centre for Disease Control showing that the cases are now coming further north. So these are around Paris, some in Germany, and the Netherlands have reported their first equine outbreak in October last year. So does the UK have the mosquito? This is a study which is showing mosquito traps, so the competent vector in the UK, and these are previously known locations prior to 2024. In 2024, they trapped more mosquitoes in these areas, so around Cambridgeshire and in Portsmouth in the south. Cambridgeshire, which is around where we're based, has a wild pony herd. They live in the fen wetlands, and these may act as an early warning system for this virus. And interestingly, these spots here that you can see previously are located along ports, so this could be another transmission for the virus. This was an interesting headline last year. It was suggesting that West Nile virus was detected in the UK for the first time. It was on further looking, a report that was on a research study done in 2023. Mosquitoes were found and they found a trace of RNA. However, that thankfully was historical and none have been found since. There is ongoing, surveillance of this and in birds, and thankfully neither have been found. We have had one case reported in the UK in 2022, but history here was really essential. This horse had moved through Spain, which is a known endemic area, and in October, which is a known high activity time for mosquitoes. So that while this horse was sick and here, it was no threat to the UK, to the people or the other horses around it, so it could be looked after in a hospital. So if you are travelling a horse through endemic areas and at these activity times, vaccinations can be considered and are available to us. It is really likely that this virus will come, and it is surveillance, generating maps of where these mosquitoes can travel that really will be crucial in containing any outbreaks and preparing us for what might be, of what risks might be. So sorry, that was very rapid fire, but I hope it's really highlighted the importance and the challenge of keeping up with infectious disease while allowing us to still move our horses around, and really emphasising that using digital IDs and tracing and transparent reporting, we can achieve this. So thank you. Sorry, that was quick.
Thank you very much, Hattie. The times that I've spoken here, I get accused of frightening people, and I think Hattie's just done the same. So I'd like to now introduce our next speaker. Great pleasure to introduce Jane Hodgkinson, who I've done a little bit of collaborating with. And Jane is Professor of Veterinary Parasitology at the University of Liverpool. So she's at the forefront of parasite research. And today, Jane's going to talk to us about a really important emerging issue, Anthelmintic resistance and the increasing challenge of effective worm control in our horses. Over to you. Thank you, Jane.
Thank you, Your Royal Highness, ladies and gentlemen. It's a real opportunity here to talk to you, and I thank you for the invitation to do that. So, if I can move it forward. So, as Richard said, I've been working in veterinary parasitology since 1999, and we've seen quite a lot of changes over that time. So I'm just going to reflect on some of those changes and kind of where we feel we are right now and the challenges we have and we're facing. No detailed parasite life cycles. This slide really is just to identify amongst the parasites that we're studying, there's really these three that stand out as the potential to cause disease. Most disease is seen in young animals. If you're looking at Parascaris, the large roundworm of animals, really you get disease in that first year. And then moving on to the strong owls, particularly the Southostomins, the fact that you see disease really from a year of age right through to 3 years, that's the risk age group for larval Southostominosis. And then with tapeworms, potentially you see disease. Anaplocephala foliata can cause disease in any age of animal, but again, you have a tendency to see this in young animals. I think really amongst the things I want to illustrate on this slide are the fact that we're very familiar. We talk about disease, we know about infection in detail in the host, in the horse. But all of these parasites have essential development that takes place in the environment, whether it's within the fecal pat or whether it's out and translated onto pasture. And in the case of tapeworms, that's obviously inside the orobatic mite intermediate host. And I'll come back to that relevance of that in a minute. Amongst the drugs we have, this is the same list of drugs that I would have given a talk in 1999. There's nothing new that's here that we haven't already been familiar with. And again, this slide is really just to highlight But depending on which parasite you're talking about, you're going to make a different choice in which drug you might use. So for Parasiticides, you might have a drug of choice, fenbendazole, whereas for cyathostomas, your option might be to use ivermectin or moxidectin. And I think the key to this is we've had praziquantel, which is used to control just tapeworms, but those four, we have there, fenbendazole, pyrantel salts, ivermectin, moxidectin. They are the only four we've had available to us for quite a while, as I said. And preserving their efficacy has really been where we have been trying to put out advice and guidelines for the last 15 years or so. And that really is what sustainable parasite control has looked like. And people like me have been going out talking about, as I say, for a decade or more. And it's essentially centers around not trying to eradicate these parasites, but trying to minimize the exposure that horses have to these most pathogenic of parasites. And in most cases, it's about preventing high levels of infection, because with the exception of one or two, you need high levels of parasitism to cause disease. So if you can control the amount of exposure, reduce the burden in the horse, then you reduce the incidence of disease. And there's 3 points I'm just going to illustrate that sort of really best demonstrate sustainable control. And the first of those is not to forget about non-chemical means of controlling these parasites, and I'll say a bit more about that. Obviously, drugs do have to be used, but using them judiciously and appropriately, rather than just routinely giving doses to large numbers of animals. That's really not been recommended now for the last 15 years. And using things like fecal egg counts to target high egg shedding horses within a herd, so we can reduce their egg shedding, which benefits those horses and all of the horses that are grazing with them. And increasingly, I've seen this shift, which has been a welcome shift, towards taking a sort of holistic look at the horse and its management and using a risk-based approach. So the most obvious, if we start with non-chemical, the most obvious thing that people like me talk about is picking up poo, removing dung, removing feces from pasture. Because if you do that, if you think back to that life cycle, you remove the source of infection. The essential development that needs to take place within the fecal pattern or pasture is not going to happen because you're removing it. And studies have shown ideally twice a week will break that cycle of transmission. Obviously, you have other hosts that are non-competent. They have, in most cases, they don't share the same parasites with horses. So grazing sheep on your pastures after you've had horses grazing that pasture can be a very useful adjunct to other means of control. And really coming back to this spans a lot of different parasites in a lot of different hosts. We do the same for sheep and cattle. Thinking about your most vulnerable age group, which is under the age of 3 for most of these parasites, and not putting them onto what you would consider your highest risk pastures. So pastures that maybe have been permanent pastures, have been grazed multiple years by horses. Ideally, obviously very difficult to achieve in practice, but if pastures can be rested, the studies show that at least a year, possibly up to 2, which is obviously to some extent impractical, but really to allow the parasites to die out, you do need to live a considerable length of time. So in terms of where we are, and a lot of has happened in this space whilst I've been working within the field, is really improving diagnostics and using diagnostics to guide treatment decisions. And the best example of that, I think most people do know, is using the fecal egg count or the fecal worm egg count. And therefore you can direct your treatments to the horses that are going to either benefit the most if it's a treatment or prophylactically to reduce egg shedding in that way. So you're really using those tests to determine whether a drug should be used or not and which drug might be used if it's a different parasite you're thinking about. But also increasingly using a fecal egg count to test that a drug has worked in the way that you hope that it will. So testing their effectiveness, using a pre and post treatment fecal egg count and looking at the reduction to estimate effectiveness of that drug. Increasingly looking at antibody detection for tapeworm, antibody levels for tapeworm, and looking at the redworm test. We're not going to go into diagnostics in any detail, but essentially those are out there too who can help in the sustainable parasite control system. And then looking at risk. So obviously this is a very big slide. It comes from Cantor. I'll mention, I know you've heard about Cantor last year, so I'll just mention it again. There are other risk tables out there, but I think what this illustrates nicely is the idea that this risk assessment is low, medium, or high risk in terms of the infection level with parasites they may have or at least have been exposed to. Takes into account any test results, the age profile of the animal, its management, to build a picture of the risk that you think or you can assess that that horse may be exposed to. Important to appreciate, though, it can't be used in all contexts. If you look at Parasquis and young stock, the recommendation is to still treat those and not necessarily to carry out this kind of risk evaluation. But it's very useful for adult mature horses. So I mentioned Canter, and we have, specifically for vets, Beaver have produced Protect Me 2. As someone in the field, I really welcome these. They've come about in the last 5 years, and they are really valuable tools that can be, in the case of Canter, multiple stakeholder groups, lots of experts together reaching consensus around those guidelines, and we've just updated them, so the new guidelines are out there. And there's a couple of young stock and quarantine documents that will be released very soon. And really, these are to help you deliver that sustainable control. But the reason sustainable control came about was to protect the drugs. And although it's been advocated for the last 15 years, we know that anthelmintic resistance has increased. So if we just look at Parasquis species and fenbendazole, we know now this is taken all from the literature, but essentially there are countries that are now reporting failure of fenbendazole control Parasquis. Similarly, countries reporting that for Pyrantel, and we've known about this for a while, a large number of countries reporting resistance to ivermectin and moxidectin in Parasquis populations. In the UK, we actually don't have any recent data. We have 2 studies, both looking at ivermectin resistance, reporting that in 2006 and 2014. And we have this knowledge gap, really. But I think from anecdotal information, we know that there are examples of, particularly on studs with lots of young animals, they are finding it difficult to control this parasite, despite using anthelmintics. So anecdotally, I think we're gathering a lot of sort of passive information because there isn't active surveillance, and we can extrapolate from this situation to what might be happening in the UK. Having said that, we are trying through our research to fill those knowledge gaps. So if we look at cyathistomins, if we were to look at benzimidazoles here, as a single dose, there's extensive benzimidazole resistance in many parts of the world, including the UK. We've had many studies showing that. And again, the same with Pyrantel salts. Slightly of concern, more recently, we're seeing larger numbers of resistance cases being reported in different countries throughout the world. And in 2023, I was working with colleagues, and we presented the first case of ivermectin resistance in cyathistomins in the UK. So again, I don't speak to a vet these days without them talking about larval cyathistominosis cases in well-managed, or what they would consider well-managed animals that have received anthelmintic treatments. In the past, when we investigated those cases, there often would have been a history of lack of drug use, overgrazing in intensive pastures, but now we do hear about these cases. As I say, despite drug treatment, we have what would appear to be drug failure. And with tapeworms, we don't have any in the UK yet that have reported resistance, but again, we're hearing it anecdotally. Sorry, I nearly dropped my glass. But with tapeworms, there are 2 drugs that can control tapeworms, praziquantel and the Pyrantel salts that double the nematode dose. And this report showed that actually, in this case, in the US, both of those drugs failed to control tapeworm infections. So this slide is quite busy, but I just want to highlight a few things. The Canter and Protect Me 2 documents are fantastic. And for many people, they're still very appropriate and very usable. And they're still trying to preserve the drugs as best we can. But we know from our work, and by trying to do the research that we're doing, that we're hearing in the UK of examples on studs where they cannot control, particularly Parasquis and especially cyathistomins. So we are essentially trying to achieve parasite control in like a post-resistance era. And our documents don't necessarily have the information to help people in those situations. And that's something we have to think about and we have to work through together. But what we've also become aware of is when we're trying to do our fecal egg count reduction test surveys, or where we're trying to engage with studs over testing the effectiveness of drugs or looking at their management practices, there's kind of a sensitivity about wanting to be engaged with those research processes. There's a concern about being stigmatized and having horses that are infected with drug-resistant parasites. There's concern about the commercial impacts of being known to have horses that they want to go on and sell if those horses are infected with drug-resistant parasites. And there's a general reluctance to engage with the diagnostics that can be so helpful in telling you whether a drug is working or not. We are working on the quarantine for Canter, and that will come out, but it's fair to say if a horse moves, it takes its parasites with it. And if the horse is infected with drug-resistant parasites, those drug-resistant parasites get disseminated out more widely in the environment. And we don't really have anything in place to look at how we might prevent that from happening. At the minute, we think it's probably fairly localized in terms of studs and young stock where we're seeing these problems, but for how long? Because that obviously can translate out into the wider horse population. There's also a complexity we've been looking at around the prescription process and who prescribes and who deals with the end consequences of drug failure. How do we don't have active surveillance for sort of drugs not working, and where does that responsibility lie in reporting that back? Veterinarians dealing with the consequences, not necessarily coming back to what we were saying before, the full history of anthelmintic treatment, for example. And really going forward, I think this is a space where we have to do more work. We have to work together, collectively, parasitologists like me, diagnosticians, prescribers, vets, other researchers, to try and establish what we're going to do faced with the reality of potentially multi-drug resistant cythostomas and parasites going forward. So I don't have solutions, but we do have challenges. Thank you.
Thank you very much, Jane. Great deal for us to consider there. I'm a great fan of the word quarantine, and I think to use it applied now to parasites as well, I think is a very sensible idea. Our next speaker, final speaker today, great pleasure to introduce Phil Ivens. Phil is a practitioner, but he's no ordinary practitioner. He's the Managing Director at Buckingham Equine Vets. And very pleased to say he's had a long-standing interest in infectious diseases. And Phil is going to talk to us today, again, about a really important emerging One Health issue, which is antimicrobial resistance. Are we winning or are we losing? So, thank you.
Thank you, Richard. Your Royal Highness, ladies and gentlemen, thank you for inviting me to talk today on this really important subject of antimicrobial resistance, which will use the acronym AMR throughout the rest of the talk, where we are in 2026, and to try and grapple with the important question, are we winning or are we losing that battle? And there will be parts of this talk that will go to the depths of despair, but I hope we'll end on a really positive and upbeat sentiment for the future. So resistance is an inevitable consequence, you've just heard from a parasitic perspective, in antimicrobials in antibiotic use. It is inherent in what we do when we prescribe antibiotics, and I'll hopefully touch upon why that's the case. And vets and other healthcare professionals create selection pressure by that antibiotic use. And there is a rapid rise in resistant bacterial populations. And challengingly, resistant genes move readily within bacterial species, but more importantly, between bacterial species. And resistance spreads beyond the original resistant population. So it's really important, this One Health subject, whether we're treating horses, whether we're treating companion animals, whether we're treating farm animals, or whether we're treating humans, the effects of antimicrobial resistance is the same. So in the top left here, we've got a streptococcal infection in the upper respiratory tract of a horse. And as a veterinary surgeon, I might give that horse an antibiotic. And the very nature of doing that is I'll select a subpopulation of those bacteria with genetic components that can fight that antibiotic. And also challengingly, these genetic components that fight one particular antibiotic tend to group together and form cassettes, for example, in the middle here, where you've got multiple genes that are resistant to multiple antibiotics. And then bacteria have mechanisms where they can transfer these bits of DNA, these, in this case, a transposon, into human pathogens, so human bacteria, that then can infect us as humans. And obviously our close proximity as people who work with horses facilitate that transfer of those resistant genes. So Alexander Fleming, almost by accident on a laboratory bench here in London actually, in 1928, discovered a fungus that produced the antibiotic penicillin. It took another decade or so for colleagues at Oxford University to mass produce this antibiotic, and amid the Second World War, mass production of the first antibiotic penicillin came to age, and that's just about in living memory, but for most of us here, we do not remember an age where there weren't antibiotics. So you can see you can buy bonds and you can thrash the Axis powers, but you can also cure your gonorrhea in a few hours with penicillin. So we take antibiotics for granted. And for most of us, most of the time, we do not realise that we're standing on a precipice of returning to an era of medicine prior to the antibiotic age. And what does that mean? It means that all the medical procedures that we take for granted may not be able to be performed in the future. We have hip replacements, knee replacements, heart valve transplants, treating pneumonia that you might get when you're on chemotherapy for your cancer would all become impossible. And so it's hard to overstate what an age without antibiotics is, both as patients and as healthcare professionals. And so we have a duty of care, whether we work with horses, whether we work in other sectors of veterinary medicine and obviously human medicine, to try and protect the antibiotics of the future. So what are we doing in equine medicine? So we hopefully all have local antimicrobial resistant policies at a practice level, and the British Equine Veterinary Association have helped practices doing that through projects that interlock and help. And so I sort of see it as the three schemes: Protect Me, which you've heard about from a parasitic perspective, but it has an antimicrobial perspective, which I'll show in the next slide. Monitor Me, which has been pioneered in the last couple of years and really championed by the outgoing Beaver President Bruce Bladen. And that's really looking at data from practice management software at practice level and looking whether our policies are affecting how we prescribe antibiotics, and are we seeing less resistance, or do we need to moderate our policies. And then very excitingly, in the next few weeks, there's going to be the Rein In Antimicrobial project, which is connecting the data that we have at local private laboratory level, because in equine world, most of our diagnostic samples go to private laboratories, and using the network that already exists to collate that information, and I'll touch upon that in a few slides' time. So what is Protect Me from an antibiotic perspective? It's an acronym. It is quite a long acronym, and I'll go through a few of these just to show you some of the examples of what we can do at practice level. So we need a practice policy, really important. We need to try and reduce our prophylaxis. So what does that mean? You know, instead of giving a colic surgery that had no surgical intervention in the bowel itself, it was just re-put in, so there's no bacteria leaking out of the bowel, it might be reducing the antibiotic course from, say, 5 days down to 3 days. And that can be done for all types of surgery. It's really important that we use the right types of drug to the right types of bacteria. So if we're dealing with a gram-positive bacteria, for example, we need an antibiotic that will treat gram-positive bacteria. And that flows on to how we employ narrow-spectrum drugs. We don't want to choose antibiotics where possible that treat all bacteria. We just want to treat the ones that are in our patient. And really importantly, and this is the data that you'll see in the Rein In project in a few slides' time that they will collate, is where possible we need to culture the organism and then base our antibiotic selection based on that sensitivity. And that's challenging in practice. Adds an extra layer of cost to the client, and it takes 3-4 days to get those culture results back. So we have to make an empiric decision as clinicians, but we need that data then to say, are we on the right course? Are we giving the right antibiotic? Can we moderate treatment? So that continual ebb. And as owners, as wider industry, we've got to work with our vet to allow them to go through that process. We need to treat effectively. What does that mean? We don't want to prescribe antibiotics for 10 days when it only needed 5, and we don't want to prescribe 3 days when it needed 5. So it just needs to be right, just the right dose for long enough. We need to monitor what we're doing, and then we need to educate our clinical teams and the wider community. So here's an example of some of the literature that Beaver provide for practices of the Protect Me scheme. And really the take-home messages of this quite data-intense grid here is that we have green antibiotics, and they're the first-line antibiotics. We have blue antibiotics, which, if those first-line antibiotics fail, we should use. And really it's exceptional that we should use these orange antibiotics. And they're third or fourth generation cephalosporins. So in our world, that's ceftiofur and cefquinone. And importantly, the fluoroquinolones and enrofloxacin. So it should be really, really rare that we're using fluoroquinolones in equine practice. And it should be, in my opinion, only on a culture that is the only antimicrobial we can use, and a condition that only requires that antibiotic. So in our practice, this would be extraordinarily rare that we would use this nowadays. So what is the new project? And this is led by the group at Cambridge University, the Equine Infectious Disease Surveillance. So our chair heads up, so no pressure here, heads up that team. And they're hoping to launch in the next few weeks gathering data from the private laboratory network. So what's the challenge? We have all this data sat there in laboratories of what bacteria is resistant to what antibiotic, but we have no way of collating that data because all those laboratories work independently. So the solution is to use the network that is already in place, that if anyone reads the Equine Quarterly Surveillance Report, that's a collaboration across industry to feed in that data from that network. So there's going to be a website we can all go to, whether we're laboratories or whether we're equine professionals working with horses. We can see what the aims are here, capturing that data, disseminating it, supporting that One Health initiative, and improving risk assessment in response to emerging AMR threats. These are the collaborating laboratories. Got Rossdale's in the east of the country, 3 counties in the west of the country, Rainbow in the north of the country, Sussex Equine in the south, and Axiom in the right, so all feeding in to this project. And there's going to be an analytical dashboard, and obviously we'll have to wait for that data to come in, but once it's available, both as private dashboard for the labs, but also a public dashboard for us as healthcare professionals, for people within the industry. And it's due to be launched, I'm reliably told, in a matter of weeks, so watch this space. So what can we do as an equine community now? We need to strengthen antimicrobial stewardship on yards and in clinics. As I've said, we need to prioritise culture and sensitivity testing where feasible. We need to improve infection prevention through wound care, biosecurity, vaccination uptake. We need to reduce unnecessary antimicrobial use in non-bacterial conditions. So, for example, a viral respiratory infection does not need antibiotics. And then we need to collaborate across veterinary, human health, and environmental sectors in that One Health initiative. So are we winning or are we losing? We are making progress in awareness, policy, and surveillance. But biologically, resistance is still outpacing our interventions. And the equine sector has a critical role in stewardship, prevention, and early adoption of new diagnostics. The next decade will determine whether AMR becomes manageable or catastrophic. And here's the outgoing president of Beaver, Bruce Bladen, hugging one of his patients. And like I say, he's done a lot of work in the last year or two with the Beaver team to drive a lot of this forward. So together, we can beat this, but we need to work together. Thank you very much, Mr. Chair.
Thank you very much, Phil. I'd like to invite you and Jane up to join Hattie. Should just say Hattie is a little bit lame, and that's why she got to the stage nice and early. So yeah, we would like any questions now. We've got a few minutes, 5 minutes or so, before we break for lunch. I'm going to ask, do we have any questions from the floor? There's somebody right at the back there. Thank you. If you could say your name and who you are, I think I recognise you, so welcome.
Neil Hudson, I'm the Member of Parliament for Epping Forest, an equine veterinarian, and I'm a shadow DEFRA minister. My question is for Hattie and Richard. Firstly, thank you for all that you do in Cambridge, and secondly, a huge big 3 cheers that Cambridge Vet School has been saved. But different species, different epidemiology, but just recently we've had foot and mouth disease confirmed in Cyprus, and we've had it in Hungary and Slovakia and Germany last year. So moving into the equine world, in terms of the United Kingdom, how prepared are we, heaven forbid, if we get an incursion of a catastrophic disease such as African horse sickness?
Hattie's heading that my way. Yeah, here we go. Thank you very much, Neil. Great to see you. Hope your new job is going well. No, great question. Appreciate all your support for us in Cambridge. We're not as well prepared as we should be, if I'm being brutally honest. There are things that we could do better. I think our colleagues at DEFRA do a tremendous job, but under a tremendous strain. They're getting pulled in a lot of directions. And I think as the horse industry, we need to be really cautious about a disease such as African horse sickness. Blue tongue virus has given us lots of lessons of what can happen with a midge-borne orbivirus that can come into Northern Europe, become established and become endemic. And therefore we need to be really alert that we pick that up as soon as possible. And where I think we're not quite there is in terms of applying vaccination, that we are a little bit short on that. The vaccines that are used in endemic areas like South Africa are not wholly suitable for what we need. There's a lot of research being done on this, and I think new technologies, as we saw with COVID, can really offer great prospects, and that's where I would like to see the industry, the scientists, and everybody working together towards protecting ourselves. Vaccines, whether we like it or not, are going to be our saviour when it comes to that disease. So hopefully that's addressed your question. Shame the Minister's not here, but there we are. Thank you. So any other questions from the floor? We have one right here at the front, and then I'll come to you over there, and then we'll go to Slido before we finish.
Thank you. It's a question for Phil. You said not to use antimicrobials too short a time or too long a time. How, when you're diagnosing, do you know what time you should be doing it for?
That is a subject that's being heavily debated at the moment, certainly within the internal medicine world, and there will be different challenges in different specialties. So whether the clinical progression of the animal is enough, or whether we map inflammatory markers, and some inflammatory markers will stay elevated for quite a period of time. And so I think there is evidence and work ongoing as to try and dissect those, but there's certainly a move to not rely solely on your lab work, and that the clinical progression of the patient is important. And peritonitis would be a good case. You know, when do you stop prescribing antibiotics for peritonitis case, and you need to use a composite of clinical data with how the patient is, what the abdominal fluid is looking like cytologically, and also the blood work. But it's a complex question of one which we are eternally grappling with.
Okay, thank you. There's a question up near the back on the left, our left.
Siobhan Dillon again. So I was thinking about the worm resistance, and also then looking at non-horse markers, looking in terms of the pasture markers. Is there anything where you can actually measure the larval load in the field? Because I was thinking, if you could understand what larval level you've got in your horse's field, particularly in a DIY yard situation, you might have extra evidence to provide to a yard manager to say this field needs resting for a long time, or we need to get other stock in here to reduce the larval level of the field so that you reduce problem with the horse.
I think you're right that increasingly those non-chemical means of control are going to be vital in assessing a risk a pasture might pose, particularly if you know that you can't necessarily rely on the drugs in the way you have been able to. Unfortunately, we don't have any good method that can accurately assess the larval burden. So there are studies that you can go out, I've done it myself, collect pasture, bring it back, wash it off, recover it. But when studies were done to look at what proportion you recover, if you seed them onto pasture, what proportion you recover with those methods, it's a very small percentage of what's actually out there. So there isn't really any good tool to allow you to do that. So then you have to infer it from maybe how that pasture has been managed. So we do know, for example, in the resistance study, there was a permanent pasture that was always used for every year's foals when they were weaned, would be turned out onto that pasture and grazed on that pasture up until they were yearlings, and maybe even a few months beyond that. And the following year's foals that were born without Cyathostomin parasites acquired their infections from that pasture, and when tested, they also had resistant parasites, and they had come from the previous crop of foals that had the resistant parasites, and were passing those out onto pasture. So no, we don't. It would be ideal if we did, if we could assess which those risk pastures are, but you really just have to infer that from what you know the management of that pasture has been, whether it's had sheep on there after horses, whether it's been reseeded, whether it's been rested at any time, and ideally not putting your most vulnerable animals on the same pasture year in, year out, because younger horses are natural higher egg shedders anyway for the first few years of their life, so there's more parasites going out onto pasture, and then if you keep using those same pastures year on year, they can just build up and then you precipitate disease situations. And for larval cellustominosis, historically, we wouldn't necessarily have associated like 11, 12-month-old young stock with having larval cellustominosis. Typically, I know I've asked lots of clinicians about this over time. We are now starting to see that, which suggests they're picking up huge numbers of parasites in just a very short period of grazing. And that is a concern. But we don't, unfortunately. Wish we did.
Thank you very much, Jane. I'm conscious of the time, and we've run out of it. So I would like you all please to thank our three excellent speakers, Hattie, Jane,